it really hasn't happened, and as much as we would have liked, and I would say that we are much more aware and engaged now with our patients than we have ever been before. It's not perfect, for sure not, and not everybody is the same, but I think the message is quite clear, and the message you've heard today about taking charge of your own body, making sure that you are going for screening, being proactive as opposed to not being proactive. These are all very important things, and things that we can talk about in the panel. So I would like to invite the speakers, all of the speakers, to come up to the front, have a seat in these very relaxed chairs, and we are ready for some questions from the audience. I think we will have a roaming microphone, and someone, Kara herself is going to do this. As I said earlier, we'd like you to keep your questions fairly short. We don't want any personal questions or diatribes. If you have personal questions you want to ask any of the speakers, you can do so after the question period down here, so keep the questions very general. We can start with anyone. I have a few questions myself, but I'd rather hear from the audience. So just raise your hand, wait for the microphone to come to you so we can all hear, and then ask a question. So I'm looking around, I don't see any, oh, I do see a few questions. Okay, right here. Mr. Lerner.
I would like to know about initial mutations and if there has been a bulge at any time during the last, I suppose, 50-odd years when we've been monitoring this. And if so, is there any idea as to why that might happen?
I didn't hear why. Right at the end.
Is this the one where it's
An increase.
I actually don't know the answer to that. I don't know if one of the genetic counselors may. I mean, that kind of answer would be based on population screening, and certainly now there are panels for colon cancer, so certainly more patients are having more even generalized testing done. I'm not aware of any data to show that there's an increased number of APC mutations, but maybe Kara or Zane may know better.
Well, I think it's maybe due to just awareness that we are seeing that people are more aware, and the community is more aware of the disease itself, and that does happen. We certainly in our center have an accumulation of a large number of polyposis patients, but we were just discussing this last week, I think it was, and we said that it would be nice if we were able to have a database where we could capture more of the Canadian population that have an APC mutation. So a number, I'm sure, are not captured as far as data is concerned, but they're still out there.
I've got two children. One is tested positive for FAP, one is tested negative. Do I have to worry about screening the second child? Like, what are the risks of cancer for the second child who's negative?
So the risk would be the same as the general population. Once you have a specific mutation identified in the family, that's when you're able to screen the other family members. So if that mutation is not identified, that child or young adult would be at population risk.
Do you think, I'm going to ask you a question too, would you screen that person, do you think, like they've had a first degree relative with colon cancer? So, we often, in non-polyposis patients, we often start screening first degree relatives 10 years before the diagnosis of that first degree relative. And so I see a lot of patients in their 30s or 40s because the general guidelines say start screening at 50 for healthy average risk patients, and so I'll often start earlier. Would you start screening these patients in their 20s, or would you treat them like a 50-year-old average risk adult?
Average risk adult. I mean, that is the beauty of genetic testing, is it can inform patients, and then people don't have to undergo unnecessary screening or anxiety, so they would be population risk.
And that's what, and so I've not run into that a lot, but I've run into that 1 or 2 times, and that's what we've taught, that's what I've recommended to my patients as well. You know, okay, so what I often tell my patients is guidelines are guidelines, and they're guidelines for a reason. But you know, every decision that I make and that I make with my patients is on an individual basis, and so guidelines don't necessarily work for everyone. But that's what I've recommended in the past.
I'm going to interject a question here as well to Jeff. We talked about surveillance, really, and screening the duodenum in polyposis. And I'm not sure if I'm correct in saying that you said that you would do them every year to the duodenum, but I think that what I would like to hear is if you do, let's say, 2 endoscopies in a row and there are no polyps or grade 1 polyps, I mean, there's a grading system, so not everyone has to be seen at that particular, or at the same surveillance interval. So I'd like you to maybe explain, just give a couple of examples of seeing maybe minimal disease around the ampulla versus severe disease around the ampulla, and how you would handle the surveillance, just to clarify it to everyone.
Yeah, for sure. So that's a good question. Obviously, we didn't have time to go into all the details. So the video that I showed of the duodenoscopy, or looking at the papilla, was actually in a patient with attenuated FAP. And so that patient was normal. And so we use a grading system that's not new anymore, but based on the number of polyps that we see, the size of the polyps that we see, and the type of polyps, where they are on that spectrum between kind of early precancerous polyps to kind of more advanced precancerous polyps. And so, you know, in someone who has, you know, next to no polyps, and so last week I did screening in a patient who had just a couple of, you know, 1 to 2 millimeter polyps in their duodenum, and that person can wait up to 4 years between endoscopies. And so if they don't have a lot of fundus gland polyps or polyps in their stomach, and there's not much going on in their duodenum, they can wait a long time. Now, patients with 10, 20, you know, many polyps in their duodenum can't wait so long. Big polyps, polyps that have had to be removed, they can't wait so long. But you know, often we can take out the polyps that are of risk and then extend the interval. So the interval is anywhere from 6 months to 4 years in general, but the majority end up being somewhere in that 1 to 4 year range. And so just because you come 2 years in a row doesn't mean you're stuck with me every year.
Yes.
Hi, I used to get, now I'm going every other year, but I used to get the endoscope and the gastroscope. So, because my cancer is prevalent in our family, we've proven that cancer is hereditary through the bowel. And then my grandfather was the first person to die of stomach cancer. So my question is, I've been doing this since I was 13, cancer research, so now we've upped it to, you know, every other year, because my polyps are, you know, I'm doing about 3 every year. So they said I can skip a year, because Napoleon says I've had my much desired colonoscopies. When does my children should get tested? Should they do the gene testing first before even setting up a scope?
It's a good question. Again, like, I think this, you know, often the best, so again, I don't know the whole, it's hard to say exactly for your family, because, and this is not the perfect form to do that, but, you know, it's based on mutation that you have and your family might have, based on the type of cancer that other people in the family have had. So it's quite dependent, and then the decision around genetic testing first or endoscopy first, I think is personal and is a great discussion to be had with the genetic counselors here, and then through them to me people prefer to be informed with genetic testing,
Yeah,
and
maybe-
some people.
Maybe get an opinion from Kara on that, the last part of that question in particular.
Yes,
The
we would-
investigation first, or the genetic testing first, or?
Yes, so if there is a known mutation in the family, we generally encourage the genetic testing first if it's right for your kids, depending on the timing, but to avoid an invasive procedure, because if they test negative, it goes back to the last other question that we had previously, that if they are negative and they don't carry the known mutation in the family, then they're considered to be at population risk and wouldn't need to undergo that endoscopy. There are cases though where the mutation isn't known in the family and you rely on screening instead of genetic testing. So you could speak to your genetic counselor, they can help you with that.
The other part to my question is the insurance aspect of this, right? Now when I fill out a form, they go, you've had a colonoscopy, when was the last one? Oh, it's been, 9 months. How many polyps in your lifetime have you been removed? And I'm like, oh my God, since I was 13. And I've been denied insurance 3 times now because, well, you're gonna die of cancer. And my great aunt just died, she had her bowels removed, but she ended up dying from breast cancer. But they said, she said, you're not gonna die of cancer because you're getting tested all the time. Why isn't the next person beside you more at risk than you because of your testing? How do you solve that? Like, how do I solve that issue?
That's a tricky one, and it is very individual. You may know Canada just passed a law in the last few months about protection against genetic discrimination, but there still is the family history and your personal medical history, which sometimes can trump that anyways. And so it's kind of a catch-22 that companies want your business, but they don't want to insure someone who might be at higher risk. So it's not our area of expertise, but I mean, certainly if you're getting screening in our mind, your risk is less, but there still is that background genetic risk and family history, which sometimes speaks for itself.
Okay,
So it's a tricky
let's go to another question, way in the back.
My question is for Karen, just regarding the mobile app. I think it's very exciting to hear that there are more and more technologies being developed to help support patients, not just at their time when they're at the hospital or the center, but when they go home as well. I'm curious if you have any data or anything you can comment on at this time about the impressions of the healthcare team's perspective on the app and any feedback that they have at this point regarding how it's working for them.
I think that the way we've implemented it is that all of the surgeons at Mount Sinai, the general surgeons, we've all agreed that we'll have our patients use the app. And we have physician assistants on our medical team that help the patients download the app so that they sort of get some support downloading the app. And it's actually our physician assistants who round every day on the patients who actually check the website each day. And I have to say that they really like it. It's a great way. They take about 1 to 2 hours a week, and they're probably following about 15 to 20 patients at a time. But they can look at the sort of the website, and because there's different red flags, they can really focus on the callback to the patient. But also, they found that those conversations are much more effective because they can actually look and see what's going on, and they're like, oh, this person's having high output and they're a bit dehydrated, and so, and they already know, and what I think the patients like is that they've met the physician assistants, they've rounded on them, they've seen them for post-op day 1, so it's not like a stranger who's calling, it's somebody who actually knows them and knows what's happened to them in the hospital, and the PAs tell us that the callbacks are much more effective. They're shorter because they know the patient, they also know what's going on, and they don't have to ask a million more questions. So that's been very useful. The physician assistants, if they're worried or if they can't manage the problem over the phone, then they'll speak to the staff surgeon, and if they're worried about something, then we've had a couple of callbacks where we've asked the patient, we've admitted them directly to the hospital because we've been worried about them, or they'll come to the emergency, or if they have a wound problem, the physician assistants will just book them into a clinic and see them for their wound as well. So we're trying to make it a little bit more efficient and hopefully to make people feel a little bit more connected to the surgical team after they leave. So I think I don't think any of the staff surgeons have had any, we certainly haven't had any problems. I think that everybody's looked upon it, as a very sort of useful thing. And I think me as a staff physician, as you know, we get a lot of pressure to send people home earlier, and I'm always hesitant to do that. But now, if I know somebody's using the app, then, if they're sort of, if I think they're going to be okay, but they might not be perfect, then I feel a lot better sending them home with the app, because we can actually see what's going on, and if it looks like they're getting into trouble, we can call them a little bit earlier and try to intervene. So I think that's what I sort of like about it as a surgeon. I don't know if Sam, you have any comments?
No, I was gonna ask you another question.
I can talk about this.
But I'm gonna ask you the question anyway, because, firstly, the response rate of 80% pretty well, that's pretty remarkable.
Yes.
Response rate, I think, for any study, a questionnaire, something like this. But where are you exactly going as far as rolling this out across the university now? What is the plan, and how much resources is that going to take, and how much money is it going to cost? All of those questions. You can answer that in a minute.
All those easy questions. So the first question was, where are we?
How are you going to roll this
How are we
program?
gonna roll it out? Well, I think that it's going to be. I think that that's a big challenge. That it's certainly not cheap to have this mobile app, but certainly I think that one of the things we were sort of really excited about was that not only did it, help patients, but it decreased the readmission rate. And that's one way of talking to our hospital administration in terms of coming up with a business plan and saying, look, we've reduced the readmission rate by 60%. This is sort of X number of hospital days that you're saving and patient days in hospital. And, this many days in hospital costs this much money, and to run this sort of integrated monitoring system costs this much money. And I think what they'll find is that, there's probably some cost savings in having the mobile app, and that's the business plan that we've sort of presented to the hospital. And they're actually they're very interested. The other thing is that the company that's done the app actually has a whole module for even pre-surgery, so that there's a lot of stuff that they can give education and information before you even have surgery. So it will, email you to tell you, to help you with a smoking cessation program. It will tell you what exercises to do. It will tell you what to eat. It will remind you to stop taking your blood thinners. It will remind you not to eat or to take your bowel prep the day before the surgery through email. And so I think the hospital also sees some value in that. It also has a system that when you're in the hospital, post-op day one, I say make sure you go for a walk now and you get an email, and you have to check off whether you've done it or not. And those milestones are sort of important so that people can sort of become engaged and take control of it. They don't have to wait for somebody to come and tell them what to do. They know what to do. But the nice thing about the app is that we can also get data back, so we know who is able to do all those things when, and we know how well we're doing in helping people meet those milestones. And so, and we think that if we do all those things, we can decrease length of stay. So another way to sort of discussing it with the hospital is to even roll it out at the start before surgery to try to decrease the length of stay and the number of readmissions. So again, as a business model. We also have a sort of pan-Canadian colorectal group, and we're sort of as a sort of pan-Canadian group of 10 high-volume rectal cancer centers. That group has agreed to use the app in a more sort of rigorous scientific study to look at readmission rates. And I think if that shows that it decreases readmission rates, I think that would be another strong sort of case for that app as well. Does that answer the question?
Yeah.
Okay.
Very good. Any questions? Is someone okay right over here on the far side?
So Dr. Kennedy is just playing off what you said, but so I was just wondering, for the patients who felt satisfied with the app, like how many of those patients are being sent home with home care with CCAC? Because one thing that I thought about was that, that feeling of satisfaction, is it coming from the app or is it coming from the fact that they have a home care nurse there, answering any questions they have. So how do you kind of separate those two factors?
I think you can't separate them. I think a lot of the patients with new stomas would have home care. I have to say, in my experience, there seems to be a lot of variation in the home care, actual care, and I have a lot of patients who think that it's fantastic, and I have a lot of patients that are extremely frustrated by it. So we do actually have, as part of the app at home, if you're supposed to get home care, are they coming, and ask about drains and things like that, if it's pertinent to your case. But certainly, you're exactly right, there's lots of confounders, and this is sort of just a pilot study, and there's lots of problems with it. So that could be sort of a reason that patients were feeling well supported, although at our patient engagement group, a lot of those patients had home care and didn't feel that they were getting the support that they needed. Partly was because the home care nurses didn't know what happened to them in the hospital. They didn't really know what was, if they were supposed to look after a wound, they didn't know, some other symptom, they didn't really know how to guide them through other symptoms, so they could deal with one thing, but not a whole bunch of different things.
Yes, down here.
So my question is, if someone has short bowel with a permanent ostomy and they get like the endoscopy, does that check the whole, like their whole GI? Well, with whatever they have left, or do they need to go through the stoma as well?
So, great question. So we certainly do not check the whole small bowel when we do the endoscopy through the mouth. Even when you have your colon out, you're left with the majority of your small bowel, and you guys can speak more to that. But we only check into the very first part of the small bowel, and so we're checking the first 10 or so inches of the small bowel, and the small bowel can be 20 feet long, and so there's a lot of small bowel left now. We know that most of the small bowel problems are happening in the duodenum, or that very first part, and so we're screening we're screening that part that's at the most risk. But there is small bowel left that is not screened.
Let me just add a bit to that, and that is that small bowel cancer in the general population is not common. Even though there's an increased risk in polyposis patients, it's still not common. So the most common area is the duodenum, and that's what we're able to check. As Jeff said, the small intestine stretched out is about 20 feet long, impossible to survey it endoscopically. There are tilt cams or cameras which one can swallow, and it gives a picture of the small bowel, but that's not generally used for surveillance purposes. So we are left with more traditional tests for the small bowel, but in general terms, I wouldn't say that it's a big surveillance feature of any of our programs.
So I was just curious because I have 5 feet left of my bowel and everything else has been removed. So that's why I was curious, like if they have to surveil it, like do it through the stoma there.
Sorry, I didn't catch part of that.
So
Maybe you could repeat it, Kara. Just
I'm not sure, are you talking about your colon or your small
no,
bowel?
so like most of my bottom bits have been removed and I have 5 inches total of my small bowel.
5 inches or
5 inches?
No, sorry, 5 feet.
And what's the question with the 5 feet?
Would the upper scope be enough to?
It still wouldn't reach us, all the 5 feet still couldn't be surveyed, even from below and from above together. You can get closer, but it still couldn't be.
So then my next question would be, they should be monitoring through the stoma, like a scope through that way?
Yes, you can go through the stoma, but again, it's limited because it's it's tortuous, it's very hurt, so it's hard to get very far through the stoma itself, although it varies from patient to patient, obviously, but still, you're not getting that far where you can see the entire small bowel.
But I guess, I guess we wouldn't routinely recommend a ileoscopy, just because we think the risk of getting small bowel, even if small bowel cancer, even if FAP is very low. So it's not something we routinely recommend, unless you might be having symptoms or something, then we might do it. So it's not a routine thing.
Anyone else? Yes, over here. While you're getting all the way over to the other side, I'm gonna ask Stephanie, who's been surprisingly very quiet here on the panel. Listening to what's going on now, you're very well aware of the disease and yourself, and what advice would you give to the medical system? Where do you think we need to go? Or what are some of our faults?
Actually, it was more the
How
other
much
way
time
around.
do we have?
I think how now we're whispering, I think being aware or forgotten how many years it's been is the advances, I think, straight away, this app and this, I mean, being one of the first families, when Daniel was pointing out, one of the first kids to have the elective surgery, the advances, I mean, right from the beginning of this thing, how you help with the children, I mean, we purposely chose a school that was then going to help work with our children. So it had to be a school where the teachers, everybody was aware that the kids were having surgery, help us plan it. I'm realizing it was an unusual situation back then for us to discuss it, or they were explaining why it wasn't for Daniel not to have surgery grade 9 or grade 12, you know, that's how he came up with his grade 10. But now there's so much more with helping the kids. There was so much when we came home. I mean, as I said, the temporary ones and coming home and had no idea how to cope with the kids. I mean, having 2 of them at home and, you know, as I said, couldn't keep them hydrated, all these different problems, and carrying IV pods up and down the stairs and all this stuff. But there's so much more now, and I see, like, my granddaughter's just started, 5 started kindergarten in the States, and the teacher, they have emails and the app, and you get to know everything. So this whole app business is just what today's generation. So, and just because I was developing the stories, I mean, I was one of the first who did the video camera that I swallowed to see if I had polyps all the way through, just so you know, it's not that I had to fight insurance at the time for that one. And to walk around for a day in the summer with all these wires was quite an interesting experience. But no, I would say, as always, know your own body and speak up. I did that all those years ago anyway with Rachel, when I thought she had a problem. I think mine is always that doctors have got to, they're terrific, but they've got to also learn to listen, especially to parents who know, or to you know your body, or to parents who know their child. My example was the fact that Dr. Cohen was away and I came down to emergency because Rachel would not eat or drink after her surgery, saying it hurt her. And the doctors would be saying, look at her, she's fine. And I said, well, I won't cause a fuss, but I will stay here until you x-ray her and see what's wrong. And as soon as they eventually x-rayed her, they said, oh, as soon as Dr. Cohen comes, she's going to need surgery. And it was scar tissue straight away, it was causing a narrowing. But I had to fight for that. And it's good if doctors will now work with parents to listen and help with the children. There was so much I was watching with your thing. So I find it very apt, all 3 speakers today, because it's just how much has changed and how much there is out there now. It's been very interesting. So, yeah.
Carol, do you have a comment?
I was going to agree with you. Even when you look at the medical school undergraduate curriculum now, the focus on listening to parents, and I mean, that wasn't material even 25 years ago when we were students. That wasn't part of it. Whereas now, I mean, there's lots of courses on it. I mean, it's definitely reinforced and taught, just as you're describing.
Yeah, as I said, there was just nothing. I mean, you know, Dan reminded me, I mean, he's already now lived longer with his pelvic pouch than he's lived without it, but it was so different back then. You were sent home and just learn how to work, what foods to eat and what to manage and how to do things. think the app is great. And my question with the app was, how long after you go home do you still have access to the medical team through it?
Usually we do it
Who's
for,
the-
Yeah, sorry.
usually we do it for, the patients have told us that they like it for day 1 to 14, so the first 14 days. And then we send out a 21 day and a 30-day one, so that, but we found that it really did fall off. Like after the 14 days, people were getting pretty comfortable with the questions. It sort of taught them like, are you passing gas? Are you having cramps? Are you vomiting? What's your gait? So they sort of got a little bit more comfortable, sort of monitoring their own symptoms, and so it really it sort of waned off after 14 days. So,
Okay.
yeah.
Sorry, go ahead.
Yeah. But I think that, Zane, you were saying sort of the 80% sort of uptake is very high, and with most mobile apps, just if it's an educational product, it's about 20%. But what the real sort of seller was for this was that the data was coming back, and we were monitoring it, and people felt sort of connected to the surgical team still. So I think that was actually the main draw, and what was really important about the app. It was part of an integrated sort of monitoring system, not just an app.
So my last thing on that with the app in the hospital is that there's times when you can therefore use the app with a question
Yes.
when the medical team might be not until that late at night before they're coming to do. So you've got all day waiting with your question, and I hope that the doctor's going to be there for you to ask that one question, and you can't leave the room until the doctor comes. So if you've got an app that you could ask the question, it's great. Yeah. So.
Certainly one of the advantages. Okay, the question up here.
I first would just like to say thank you to all of you. It's been very informative, and we've really appreciated all the help as a family we've had from professionals over the years. My question is actually, and I'm not sure if you can answer this, but is anyone actually working on a cure for familial polyposis?
Well, I think that the answer is yes and no. It's not sitting on the fence there. I think we are learning more, for sure, about the development of polyps and the polyp cancer sequence. And there's much research going on that, and the development of cancer and the type of cancer, and looking at the cells themselves within the cancers. I do think we are making progress there. There are preventative studies, at least a couple going on now. We're involved in one, looking at the decrease in the size and number of polyps with a certain agent, and there's an international study ongoing on that right now, that I have some kind of mixed feelings about that study, because it's not a curative study. It's somewhat of a preventative study, but my criticism of that study is that we're just delaying the inevitable, and that may be important in certain cases, particularly in younger patients, where you do want to delay it potentially a little more for various reasons that patients and their families have. So directly, I don't think so, but do you have any other answer to that question, Carol? Or maybe?
I guess it is a big question. And so unfortunately from the genetic side, we can't change our genes or do anything about that, but really it is just more about the focus on education and early intervention. We can try to prevent cancer, but we can't change the fact that someone has FAP.
There is genetic research that would look at conditions such as cystic fibrosis, where they're able to really modify the genes. So, I'm optimistic that there will be the ability to work with genes with all the genetic research. There's certainly animal models looking at this. So I'm actually more optimistic that we're going to be in the next, I'm not sure when, better to understand many genetic conditions and have the ability to alter the phenotype, how it actually plays out.
In certain diseases, we are able to, or not we, but the researchers are able to definitely alter genes, and I think that's where the answers will come.
My question, Karen, you might be able to answer this. When I was falling pregnant, I had to go through fertility. And at the time, the fertility doctor suggested that they could test my eggs for familial polyposis and then fertilize those eggs that did not have the gene. But the geneticist said no way, it's ethically, they cannot allow that. Now, I don't know, can you give me a little bit about the ethics, genetic ethics in Canada and whether that would be allowed today?
Genetics is definitely changing all the time. Kara's gonna jump in as well, but it is definitely worth seeing the genetic counselors because it is changing all the time. There's the ability, there's pre-implantation diagnosis where embryos can be tested. So for many genetic conditions, this is used all the time now. There are many different options that are available, certainly in North America and many other countries. Kara may want to add to that as well.
That's exactly what I was going to say, that I don't know what, ethically what the laws were at that time, but now certainly it is available. It is a fee for the patient, it's not covered by COVID. And it means going through IVF for some people that might not be having fertility issues, that might not normally need to go through IVF, but going through that process and then fertilizing, doing genetic testing on the embryo, so not the egg, but the fertilized embryo, and implanting ones that don't have the mutation.
Thanks for that. I think I'm going to bring the question period to a close. I appreciate all the questions, and I hope that you have enjoyed and learned from this. I would ask that you fill out your evaluations. These are very important in planning the next polyposis education night. And in their absence, I do want to thank the Heller family for being so supportive to our polyposis efforts in our research center. They have contributed a lot. They have suffered a lot as well. They have contributed a lot, and we appreciate them very much. So thank you again. If you have any questions, particular personal questions you want to come down and ask us about, then the panel will be here for another 15 minutes. That's it. Thank you very much.